There you go. Hi, everybody. Thanks for joining the December VTC Wilderness Medicine Journal Club series. This session is on cave rescue, and we are joined by one of our fellows who's currently living it up down in Bonaire, Bree, who has done quite a bit of caving and cave rescue training, and Jory Zimmerman, who is going to be our volunteer speaker. And shortly, Eric Stanley, who's a rescue squad medical director and EMS director in Blacksburg, Virginia, and an ER physician as well, will be joining. I'm going to hand things over to Bree, and then Bree and Jory, why don't we start off with the article on the 12-day cave rescue case report.
Sure. I covered two articles here. They were kind of both amazing cases, although completely opposite, but both had great outcomes with their patients. I'm just going to share my screen here because I have like a little PowerPoint, so it'll keep me kind of on track. Let's see if I can share this. And then, can everyone see that? Okay, I didn't. Can everyone see this screen?
Yes.
Oh, good. Okay. So I didn't add all sorts of fancy animations and things like that, but case report one is medical and logistical challenges and care of a 12-day cave rescue. Just because I feel like everyone does this, I have no disclosures, so I thought I'd let you know that. All right. So what happened in this cave rescue? This cave took place in Bavaria, Germany in 2014. Three middle-aged gentlemen went cave exploring at a depth of 1,000 meters, and they were about 6.5 kilometers from the entrance. So pretty huge cave. They did show a picture of it in the journal, in the article. If you saw it, it was pretty impressive. In 53-year-old male fell. He sustained a blunt head trauma. He had loss of consciousness. He had initial GCS of 3, and his rescue duration in total was about 12 days. The first rescue physician arrived on scene at 3.5 days after the incident took place, and then another 1.5 days before the extraction started on day 5. And then it took 7 days to extract this patient, which is amazing. The rescue took 12 days in total. It involved 728 rescuers, 202 working directly inside the cave for a total of over 9,000 hours. 7 physicians from 5 countries, and 100 hours of helicopter flights for personnel and supplies. Just a crazy, crazy huge rescue. All right, so how did the patient present? So the initial GCS was 3. They were noted to have recurrent tonic-clonic seizures every 20 minutes for about 30 hours, and after about 8 seizures, the patient was found not breathing and down, unresponsive, and the partner did CPR. He did regain ROSC. We don't know exactly how long it took. It didn't state in the article. And then after the physician arrived, he noted there was anisocoria, there was severe dysarthria, anisocoria, left arm plegia, and left leg paresis. He was hypertensive at some points during this. We don't really know. I'll go over later the treatments, but we don't know what he was treated with or really how hypertensive because it didn't state. And then he had suspected rhinoleucorrhea by the rescue physician. And I actually had to look this up, but this is like a clinical feature that describes a phenomenon when CSF drains from the skull base through the paranasal sinuses. So I assume that there was some sort of, serous fluid coming out of his nose or something like this to, denote that. All right, so initial treatment, the partner split. One went to go get help, and one had the other stayed with the patient to manage. I think the best thing he probably did for his friend was put him in a hypothermia wrap with a sleeping bag. Good job. And then the CPR and regain consciousness. It doesn't really go into too much detail about what else he did kind of prior to the medical support arrived. Just that, he kept him warm, he kept him, safe, I guess. And then he did the CPR. I don't think that he had any medications or things like that with him. And I'm not really sure how much he was eating, to be honest with you. This guy was in and out of consciousness with a low GCS, so I'd be surprised if he was taking in much enteral nutrition at all. By the time the physicians arrived, his GCS had improved to about 13. And then they started giving 8 milligrams of dexamethasone for suspected increased ICP. That's for the unequal pupils. He gave him the cefuroxime for meningitis prophylaxis. They gave him an IV, fluid resuscitation. They gave him a Foley and monitored fluid management and balance. They took vitals, glucose twice a day, which I don't think that that's that much, especially if you're, monitoring someone for increased, intracranial pressure. But and then after 6 days, they started Lovenox prophylaxis for thrombotic prophy. Um, and then they initially gave him nutrition parenterally, and then later gave him probably like Ensures or a densely caloric drink. And then again, the hypertension was treated, but they didn't really say how much or how it was treated. Post rescue, the imaging at the hospital, he had an intracranial hemorrhage with mild midline shift, a small epidural hematoma, and fractures to the maxillofacial bones. He spent 6 days in the ICU and was transferred to the floor, and then was discharged on day 14 to rehab. Unbelievable, full recovery at 6 months, and he's a physicist, which is like just amazing. So just some things that I looked up just to see, kind of what other things we're doing. There was an article on the WMS that was kind of managing traumatic brain injury in military guidelines to the wilderness, and there was this pretty cool chart. And nowhere, I couldn't find anywhere except on UpToDate, about some stuff using dexamethasone. But if you read through this whole chart at the bottom, it says, okay, use hypertonic saline. Um, I I would be nervous to give hypertonic saline at the depths of a cave as well, just because it doesn't say that they were using an ISTAT. They weren't monitoring, blood levels or sodium or anything like that. And so anyway, guidelines posted by the US military, I'm sorry, that's to the right, translated by WMS, states that if patients are asymmetric, and they recommend giving 250 cc bolus of hypertonic saline to help reduce intracranial pressure. And like I said before, they weren't like vented or anything like that. His GCS was 13 at that point, so they have no reason to do that. Alternately, I found this article on the NIH, and it was completed a study of 30 patients with traumatic brain injury, and they were given dexamethasone, and their intracranial pressure decreased from 22 to 19, which is pretty cool. Just so we all remember, the normal is about 7-15, still above normal, but pretty good. At least some improvement there. Um, and then according to UpToDate, initial management of TBI should both prevent hypotension and hypothermia. UpToDate also suggests that pre-hospital intubation is somewhat controversial, although there was a few different articles I was looking at, and some were like, it's not great, and some were it's great. There was one in Australia, and so some demonstrated better outcomes at 6 months. Either way, there was no intubation here. The initial rescuer didn't have any of that, for the low GCS, and he improved. Spinal immobilization is always recommended, and I'm not sure if he did that. It didn't really mention either. Probably would have been a good thing in the hypothermia wrap since he had a TBI. And then in regards to hypotension, UpToDate suggests there's no evidence to support the use of hypertonic saline. So, you know, and then as far as seizures go, I didn't find any guidelines that were for the seizure treatment of people in the wilderness, but I would assume it's similar to that in the hospital. And then if people have a low GCS, I found on UpToDate, NIH is saying that you can use rectal diazepam, and that's approved for out of hospital treatment for repetitive seizures in children. Nowhere in this article did it say that there was any benzos given for further prophylaxis of seizures or anything like that. In the hospital, you'd give benzos, imaging, EEG, neuroconsults, all that. So things that I had thought of. I think it was that, first of all, that it was amazing that his GCS has improved, and he returned to 15 by the time he was at the hospital after such a long transport. I don't know if this was like an extraordinary case of luck or just good care. There wasn't a ton of, detailed mention of all the care that had been done. But I think overall, with over 700 rescuers involved, that's quite the collaborative effort. So I guess my questions were like, how come no anti-epileptics were given? Should vitals have been taken more often? Is there no guidelines on how often things that should be taken? There was no pain management stated throughout the article. Was this luck or excellent care? I don't know. And then those references. That's the other one. Okay, that's what I had for the first one.
Let's take a pause before case 2 and maybe like run down that case, the first one, a little bit of logistics and how it relates to actual caving. So Dr. Stanley is on now. He is
I'm
an amazing
sure.
caver. He's with the VPIK club. So Dr. Stanley, do you want to mention a little bit about why it takes 12 days to get somebody out of a 1,000-meter cave with 7 pretty serious drops.
Yeah, sure. I'd be happy to comment on that. So let's see if I can get my hi. Great. So a cave that deep is a real logistical nightmare. And when you think about the people on this planet that actually have the training level to get down to the patient, it is a very precious few that can actually access the patient, and then an even fewer that have the medical training that's required to make the type of decisions that you would need to make in a case that's this serious. So for a cave that deep on a good day, a top 1% caver who's going to go from the top of that series to the bottom is probably looking at least a multi-day trip. So, I mean, that's going to probably be, at least a camp at one site before you can even get down to the bottom level where this patient was. So the logistics of getting there are very complicated. The rigging that's involved just to get a single operator down, like so just yourself as a caver down, are extremely complicated. And to change that rigging profile from a one-person access type system to the type of rigging that's required to actually remove someone is extraordinarily complex. And there's only, like I said, a handful of people in the world that are currently probably skilled enough to do that. So when you add in the complexity of trying to make medical decisions in that environment, again, there's just not many people that have the training both from the rope side and the caving side and the medical side to be able to kind of make those decisions. So it certainly slows things down and complicates it, and oftentimes turns it into a very complicated game of telephone. Does that get to the heart of your question? I might have been rambling.
Yeah, no, I think that was great. In the cave world, there's training you can go through if you're interested, but it takes a lot of time, years of experience, years of skill to be able to pull off something like that. And as you saw, 700 people, I mean, you need a huge labor force that rotates, as well as, I don't know if there's one doctor, multiple doctors, even if they were physicians. So my suspicion is that they probably didn't document or at least in their report all about every single medicine they gave. I'm sure they gave pain medicine, things like that. And then regarding checking vital signs, that's a great question, because once he was a little bit more stable, it seemed like they were checking them at first quite often, but after a few days he was more stable and they went to twice a day. Every time you check vital signs, so you'd have to fully unwrap the patient. A cave hypothermia wrapping, I mean, you're like a mummy in here, and you have rope rigging and all sorts of stuff around you. So you'd have to de-rig the patients, open them up just to check any vital signs. So as long as they're breathing and talking to you, that's kind of our, check that we do quite frequently. And then, they do proper stops every couple hours or a couple times a day to do vital signs.
Yeah, vital signs are a fascinating question underground. Yeah. One of the things that always crosses my mind is who's asking about the vital signs and what are they going to do about it? In our area, it's common for me to show up to a cave rescue or any other number of physicians who can get to the patient's side. So if topside is asking for the vital signs at that point, what are you going to do with them? Like if you've got a physician at the patient's side, evaluating the patient, making medical decisions, I don't really know what topside needs with the vital signs. It's sort of like, here they are after the fact, in my opinion. So that's kind of an interesting problem. But when you have physicians at the top trying to relay messages down to providers that may not have that same level of training, there's certainly a role for it, but it gets very confusing once you introduce physicians into the system.
I think there was definitely some mention about the poor communication and how difficult it was to get communication down to the bottom of the cave in this article. And they were, using, text messages all the way down, and it was like playing telephone. And then in terms of like vitals, I guess that I would see that as important when you're like monitoring intracranial pressure and like trying to, manage something like that. But yeah, it's a good point.
So if you look, I don't know, let me share screen for a second here.
Sorry, I didn't put that in. I should have put that picture in.
Actually in my camera. Yeah, so I'm not sure if anybody can see the map. If you all have the article in front of you, if you actually look at the map and the timeline, so after the time of injury and the initial pace and assessment, the one companion stays with the patient. One takes 12 hours to make the ascent back to the entrance, call for help. An ER doc gets there 3.5 days after the initial injury. They don't actually move him from the site of accident until day 6. And then if you start looking at the map, like they make decent distance every day, but I mean, they're 1,000 meters. It's meters, right? It's not feet.
1,000 meters.
Yeah, so it's
And 6.5 kilometers.
underground.
6.5 meters from the distance wise or displacement wise, I suppose, 6.5 meters, 1,000 meters, just pure depth. That is a remarkable way to the entrance. So the next article actually goes into like incident command structure, supplies, resources, communication needed for a cave rescue. And I think whether we do it after that article or before would be fantastic. But Bree and Eric, would you mind working if you have I mean, I can awkwardly hold this in front of the camera if you would like, but going through the different pitches and pits and nooks and crannies, what exact like skill set and equipment and difficulties would you see, not just accessing and extricating just by yourself, but as a team getting a patient in a stretcher out? What would you specifically see in a cave rescue that makes it so different than everything else?
Bree, do you want to jump on that? You've done NCRC level 1. You know what it's like. And 2, have you done 2 yet?
Level 2.
Yeah, okay.
Signed up for level 3 in New York.
Solid.
Okay, you're good. All right, so if you look on the map, it's kind of to the right and on the bottom, the accident site. I mean, you see all this little spider web of pathways. Basically, a lot of these are drawn relatively to scale, so the bigger black pathways probably can walk through, or at least are wider. But you can see how thin some of those small black lines are. And so to get a patient through those, we often use skeds, which are the orange plastic, kind of semi-rigid patient transport devices, because they can really fit through the smallest spaces that like a Furno or a rigid litter just can't do. So a lot of those, I mean, those are 90-degree turns, you're crawling with the patient, you're pushing the patient, someone's pushing, someone's pulling, you're crawling right by, the patient's nose is here, here's a rock. And then the horizontal passage for day 7 looks like it should be pretty nice with a couple of pinches into and out of it. Camp 4 has a little descend that they probably had to rig for a safe lower. And then we get to this first 150-meter pit. So, I mean, that's 150 times 3, guys. 450 feet, thereabouts. I mean, that's huge, complicated, technical rigging. And then it's just pits back to back. I mean, a 70-meter pit, 30s, 40s. There's a narrow canyon, which hopefully they didn't have to go through unless they went through that and back up to the left to Camp 1. And then after all of that, there's another massive 180-meter towards the top, and then a 60-meter. So when you do a pit in a cave, there's a patient attendant. So the patient is being hoisted, and an attendant is normally being either raised or they're climbing their own rope to be right next to the patient to protect them from rocks, because caves are 3D structures, right? So as the patient's going up, a rock may be coming this way and you need to push the patient out a little bit this way or turn them, squeeze them through things. So it takes a ton of manpower to get one person, even like a quarter of a mile. It takes a lot of time and a lot of manpower.
Yeah, just to kind of echo some of those concepts, like when you're looking at this from a rigging standpoint, each of those pit depths that are noted would probably take 3 to 4 times the amount of rope that you would normally need. So each of these pits would probably have been rigged for single access. So you got one line that goes down. But when you shift into a rope rescue, you're going to need at least 2 lines for your patient who's being hauled out. So you've got a main and then either a belay or another main that's tensioned, just depending on how you choose to go about it. A lot of ways to kind of chase that. And then you're going to need another rope for your attendant. And then on top of that, you may just need some access lines for other people to be able to go up and down to do different tasks, to kind of pull tension on your sked or your stretcher or whatever you have, to kind of help maneuver it around different points. These multi-drop caves are often rigged in a way that there's lots of what we call rebelays. So, you may have a 180-meter pit, but, maybe only 60 meters of that rappels nice and clean. And then you get to a spot where you have to stop and we redirect the rope around obstacles. And then you have to pass bolts in the wall and, do some complex changing over from one line to another. When you introduce a patient into that environment, you then have to take the patient through all that complex rigging as well. So it's a very time-consuming operation, not to mention the space constraints that you run into. So if you have a 180-meter pit and you don't really have a great place to set each haul team that can pull, to actually do the physical lifting for the patient out, if your space is limited, then you're building complicated systems for mechanical advantage. And all of that mechanical advantage eats up rope, so if you have, like, say, a 3-to-1 mechanical advantage system, you're going to need 3 times the rope to pull through there. So the amount of resources that you need compounds very quickly for that.
It took me a second to stop sharing so I could find the unmute button. All right, thank you. Yeah, I was looking through the article and Bree just chose a fun one to start us off with. So it's about hard to find something more remote and austere than like that initial patient accident site of this cave. I suppose maybe if this happened in the middle of Antarctica, that would be the only way to make it more difficult.
Yeah.
So I think our next article would be a good point to go more over like the specific incident command and communication difficulties that compound off of an already difficult scenario. And whether we want to do it now or afterwards, I think would be a good post discussion. But any questions from the audience on that first article or comments before we move on?
I might have missed this, but did they talk at all about what treatment he needed once he got to a hospital?
Very briefly. Jory, do you want to touch on that?
Yeah, they really didn't say much. They really just stated that he was in the ICU for 6 days. He ended up going, for another 8 days. He was on a step down, and then he went to rehab. It didn't state any specifics about his, care, but I mean, he got imaging, and obviously there was a neuro consult. I mean, all the things that you would do in a hospital, I'm sure that they did for him while he was in the ICU over there. But it didn't state specifically.
Gotcha. I think like you, I'm also really surprised that somebody with what sounds like, hemorrhage or intracranial pressure to the point of anisocoria did okay for so long. And I was just curious if, maybe he needed a procedure or something that would help us gauge how serious it was.
I think the whole thing was like really miraculous that he just made this full recovery, no issue. And even over the course of, the ascent, he made such a recovery. By the time he got to the hospital, his GCS went from, 3 to 15. It was like, that's pretty incredible from being in a cave.
Yeah, definitely.
Really, the only thing they give is they give the CT imaging. So it's a decent bleed. And that's, again, 12 days post injury. but it's not insignificant. One of the interesting things that I was actually texting Bree with when I went over the articles with her was that likely difficult decision on day 6 to start Lovenox. So they highly suspect bleed, and correctly, but since they're not even just bedbound, they're like kept in a hypothermia wrap, maybe not 24/7, but starting a blood thinner in an austere setting with a suspected brain bleed must have been just a tough to call.
That's wild. I'm guessing prophylactic dosing.
Well, I'm sure it was, they don't mention a dose. I'm sure it was like 40, nothing too extravagant, but hopefully it didn't worsen anything. And it sounds like they made the right call, I suppose.
And those of you who sort of work more in the emergency setting, have you seen this sort of like I don't want to say self-resolving, but self-walling off bleed that happens that fast?
I suppose usually the ones I get, hopefully, are, somebody goes to visit grandma on a holiday, and then they find them down. And then you never know the timeline for them. But most of the time you get like a fall at home and it's next day or something like that, same day. But most of mine is just ER setting, and I don't see the post 12 day. So anybody have more of an inpatient view?
I mean, personally, you don't see people recover like this always, right? I think in my experience, I don't want to say it's like 50-50, but you have most of the time, like people don't make a full recovery like that. And I don't see people 6 months out either, but and I do like ICU, I'm a nurse practitioner, and I was an ICU nurse, but I mean, I don't think, definitely not that quick do I see recovers normally. I think it's pretty incredible.
Well, cool. Jory, why don't you take us away with the next one then?
Sure. Okay, so I didn't have quite as much for this next one. It was also pretty amazing, I think, the recovery that was made. This was like ideal case. Like if you're going to be rescued in a cave, this was the case that you want. You want to be the guy here. It was almost like, and I kind of mentioned at the end, like they could have drawn straws and been like, who wants to get injured on this case? This was so this is they're kind of more talking about their technology in this. And so this was a case that happened June 3rd, 2017. It was a training exercise by the National Alpine Cliff and Rescue Corps in Italy. And so there was a bunch of them around. They already had, a hospital, like a pre-hospital set up. They called it an AMP outside the cave. And so one of the volunteers fell from a height of 4 meters. He injured his leg, and they were at a depth of 120 meters, and they were only 1.5 kilometers from the cave entrance. So there was immediate rescuers. I mean, there was 5 of them there immediately, and the rest of them walked out to go get help. There was medical support on site. None of the people that were in the cave were trained medical professionals, but they were literally a rescue team that was just sitting there. So that was kind of lucky for him. Not usually the average patient that's going to get that. You're not always just sitting there with like a cave rescue team. So that was pretty fortunate for him. Just to talk about some of the technologies that they had on this rescue, they had this air maze, and they talked a lot about this in the article. And basically, this was a technology that was developed 2 years prior to this by them specifically for cave rescue communication. It's a digital transmission. It's basically they refer to it's like a copper wire that I'm imagining how they described it as a copper wire Ethernet cable that they lowered into the cave to give Wi-Fi at the site of distress. And so basically it's just a Wi-Fi system that they install in a cave. It's portable. They can bring it wherever they want. And then they have Ethernet, basically wherever they go. They had an iStat, which is a great thing to bring, into a cave. It's portable. They can monitor all the blood levels and electrolytes and everything like that. They had, I don't know if this is a technology, but they called it an advanced medical presidium, and this was their in the bottom right, like I picture like a medical tent outside the cave where the medical staff is waiting just to see. They had a life pack, the Schiller Argus Pro life pack, basically. So it's a 12 ECG and an AED defibrillator. And then they brought one of the, portable ultrasounds in. So it could have been, a butterfly or whatever you want. And this is, great technology, I think, to bring worldwide, and super, super easy and portable for anyone to bring in, to help diagnose anything in the cave. So, anyway, initial medical treatment, 5 people left to go get help, and the 5 people stayed with the fallen injured guy, and then the rest of them went. There was medical support within an hour. 2 anesthesiologists that were trained in cave rescue and 2 emergency nurses came. So they put a hard cervical collar on a backboard. They immobilized his leg and they splinted it. He was placed in a tent and insulated for hypothermia. They gave him 1,000 milligrams of Tylenol. They put a 16 gauge peripheral in and gave him a little bit of crystalloid. They did an EFAST exam with the ultrasound, and then they ultrasounded his knee as well. And then they decided, that he had some sort of injury there. And obviously without, an MRI or some sort of advanced imaging, they couldn't tell exactly what it was. It ended up being a ruptured ACL. But what they did was they used some levobupivacaine, I can't say it, and injected, they did a block. And his pain level went from, a 10 not being able to move to he was pretty much able to walk out of this thing, which is incredible. So they did an adductor canal block, and there's an loco-regional analgesic procedure. Objective findings: he had increased respiratory rate. I don't know. He was in pain. SATs were normal. Blood pressure was a little high. Again, he was in pain. Heart rate was normal. He had a normal GCS. They used the ISAT. All of his levels were within normal limits, so no real issues there. They also did on the EFAST. They didn't find any pneumothorax or anything that was concerning within the thoracic cavity, which was good. Just a little bit of pain, some bruising from the fall and things like that. So other than that, like I said, like I'd be surprised. Like, who wants to get injured on this one? Okay, because we're gonna walk you right out of here. So they had all of these people on standby, and he ended up splinting his leg, putting his arm around another guy, and walking out of this cave, which is absolutely unbelievable. And he states in there that he was extremely satisfied with his rescue. I thought it was kind of funny. I would be pretty satisfied too. I didn't have too much else for this, but like, this is an ideal case, right? This is where medical support was on standby. They had tons of technology. They were right there waiting for something to go wrong. And that's just not the case. They weren't super remote that it took, 3 days to get to him and 9 more days to get out. And they walked him right out, and he was in a hospital and he was okay. I mean, I think that this is probably, the exact opposite of the other one in terms of, logistical nightmares and caving. And then a couple references.
This article for me made me smile because basically you could tell that a bunch of very trained medical professionals were nearby.
Yeah.
I mean, they got an ISAT in the cave after a fall, which is, sure, but not necessary. They did a nerve block and all these things, which is great, if they did have a sicker patient, to have those skills and to do practice. But Eric, or Dr. Stanley, do you have any experience or knowledge on the communication, like this Ethernet system that they used?
Not directly. I'd be really kind of interested in it. We have a radio antenna engineer in our local cave rescue organization, and I bounced it off of him. He's like a kind of wily British guy, and all he told me was, it sucks. So I don't know what to make of that. Communications in cave are notoriously difficult. So, you don't have any cellular service, you don't have GPS signal. It's very hard to do anything other than direct line of sight radio transmission communication because of the density of the rock. There's just so much interference there. So by and large, the way that communications often occur in cave is to physically pull a military phone wire from the surface all the way down to the patient. And you connect these hard phones on each end that you can, spin a crank and ring like they did, like literally in the 40s. And you can do voice communications back and forth on that. The interesting thing about that is you can go to any point in that wire, splice in and communicate to the top, or just bare the wire and connect it to alligator clips, and you can have like a party line, like multiple people can be able to listen and talk, as long as your little phone has power to send and receive. So that is typically the way that it has been done. There have been a lot of other attempts to do different things, so different types of ground penetrating signals that can communicate back and forth. They work with various successes based on the depth of the cave, to be quite honest. Like the deeper you go, the harder it is to do anything other than a hard line. And pulling that line can take an awful lot of time. So when you look at a cave rescue like the other one that we were just looking at, like a multi-day scenario, yeah, you probably have time to get that line down just because the rigging is going to be so complex. It's going to take a few days to set it up and get ready to move from one camp to the other. You probably want to stage in areas that are easy to manage, already have food reserves and sleeping plans and space and all that. But for the most part, that's really the only way to do it. And short of that, it's literally running messages written on paper from point A to point B. That's the only way to get information back to the surface. So, from an incident command perspective, if you're in IC and you're trying to get information from the cavers in the cave, it can be very frustrating because it comes in short snippets. It's often misunderstood, or it's handwritten on a piece of paper that could be days old by the time that you get it, especially in a case of like a 12-day rescue. So it really adds some confusion and complication.
I think I imagine that this air mace line is probably like what you're describing. It's like it's an Ethernet cable that they dragged in there on like a spool and just wired, the cave pretty much. But they were able to supply Wi-Fi down there, and then they could text message back and forth with it.
Hey, Eric and Bree, can you talk us through kind of like how the incident command structure, or like the initial call would go out, or if it was for like the Blacksburg Rescue Squad? Sorry, I don't know what that was. And then you get your specific cave rescue team activated, and then you get the personnel needed, the logistical staff. Let's say that first case happened in Blacksburg, which I know we don't have that type of cave, but if we did, how would that look from start to hopeful successful finish?
Yeah, that's definitely an exercise in like nerding out into the 911 infrastructure in the United States. If we had a cave rescue call in Montgomery County, where Blacksburg Rescue is located, it would probably come either directly to the 911 center, like someone would just call 911 from Montgomery County, and it would go to our PSAP, and they know that the regional resource is Blacksburg Rescue. So they would in turn dispatch through our normal pathways. Internally in Blacksburg Rescue, we have a technical rescue division. So that is things like our cave rescue team, our ropes team. We have swiftwater, diving, trench, ground search and rescue. So within that infrastructure of our technical side, we have a dispatch structure that does just our incidents that is separate from the 911 EMS dispatch. So once that call is received from PSAP, it would come back to Blacksburg Rescue, and it would be dispatched from our technical rescue side to our technical rescue members, to their phones. Essentially is how we're doing that now. And then through some EMS software, everybody kind of responds and marks up, and we do all that. Interestingly, when a cave rescue occurs outside of Montgomery County, which is really the most common scenario because the limestone that we have in Montgomery is kind of meh, but like the next county over, Giles, is full of great limestone. And then even over the state line into West Virginia, like some of the best limestone on the East Coast is over there. So we have memorandums of understanding, MOUs, with different localities from all the way from Giles into several counties in West Virginia. When they receive a 911 call for a cave rescue, which is by far the most common way that it occurs, the 911 center from whatever locality they're in reaches back out to our PSAP, and then they in turn dispatch Blacksburg, or rarely, if a caver calls it in directly to one of the cave rescue members, we'll internally start our dispatch and then notify the state of Virginia, which is an important piece for us. So VDEM, the Virginia Department of Emergency Management, provides basically all the cover for us. So when we get dispatched to either a cave rescue outside of our county or in another state, it is VDEM that is providing us with basically our insurance to show up if we get injured there, and covers us for all of the liability that could potentially be assumed for helping. So it's nice to have the state kind of shelter you. That might have been deeper than you wanted to go.
Any questions from the audience or comments on that article?
I was curious. I don't know if everybody else is kind of an ultrasound nerd, but that block is very interesting to me, and choosing that to do that particular block and even some of the risks associated with that. I don't know if anybody has experience with that particular block or not.
I don't think I have before the adductor canal.
Yeah, I was just kind of interesting. It was more an ultrasound thing, but you do a block. There's an actual knee block that you can do for the genicular nerves of the knee itself. This particular block for the saphenous nerve is the main one you're trying to hit, which is mostly a cutaneous nerve that can innervate some of the medial knee, but it's not the whole knee itself. And if you go up high enough where it's mostly done, you can hit the nerve to the vastus medialis too. So theoretically, you can get motor blockade and not be able to walk out and take a rescue from somebody that could potentially walk with support to having actually haul a guy out.
Great points. That's something I hadn't thought about too much. You know, they mentioned it, and I was like, that's an interesting block, or the fact that they did a block, really. Oftentimes, if you splint somebody and use a buddy support system, they're pretty good on movements and able to kind of hobble out.
Hey, I'll just jump in real quick here. I have actually used blocks in technical rescue before, and I think this article kind of does highlight, like, in the right context, it can be a game changer. Like, you could, in this case, it made someone walk when they couldn't walk. I've used it before to help facilitate a difficult shoulder reduction that went from someone needing assistance to like easily walking out with no pain. So it would, I think that in the right context, I think it really highlights, like, it can be a game changer if you can get regional anesthesia and not give someone narcs or not sedate someone, or really fix an orthopedic injury to make someone able to help themselves better.
I think they were pretty stoked in the article and mentioned it more than once that they, didn't have to use any other narcotics, and even post care, they didn't. I think that was a big point that they were trying to hit home, as they used the block, and then they didn't have to give a whole bunch of other pain medicine as well, which they were pretty proud of. And they were like, we're going to try and make this, standards of care kind of a thing.
Yeah, it's a great point to get someone with a mild to moderate injury out. I think in the cave scenario, you do have to think about, like, one, if your ultrasound will even work down there. I'm not sure if all portable ultrasounds would work. They should if they're hardlined into your phone, but caves do weird things. Secondly, it's more things that you have to carry. So they only had to go, 1.5 kilometers, which is a pretty short distance. Sounds like they went down a drop. So that's totally feasible. You just add it to your cave pack. But if you're going a ways, like if you're going miles or days into a cave, that's another half pound to pound that, you're carrying, depending on like what exactly you have, the casing. And then not to mention that caves are wet and dirty. So there are like really wet caves, there are really dry caves, a lot of caves in between. So you have to be mindful of some of this equipment. Can it withstand the cave? If it drops in water, if it gets soaked by a waterfall, is it just going to fail?
not sure if you saw it in the chat, but Michaela asked about what kind of medical screening or advice or precautions would you recommend for those who want to specifically participate in cave descent? I'm not sure if you mean like just spelunking or cave rescue or extended time underground in general, but any recommendations for screening and recommendations?
You know, from my standpoint, I would say for any cave trip, the two most important things are one, go with people that have knowledge of caving. So there's cave clubs throughout the United States. We call them grottos. They're chapters of the National Speleological Society, the NSS. And anywhere there's caves, there's probably a grotto. So number one, I would say try to go with the grotto because they're going to be the folks that have the knowledge base for the caves that are local and how to do it safely. My second thing that just is kind of like a generic statement is make sure that if you do go caving, either with or without a grotto, that your trip is signed out. And in cave culture, that means that you have told somebody where you're going, specifically where that location is, and when you will be back. And then if you are not back by that time, they understand that they should initiate a rescue. Call the people that know how to do the thing to go find you and make sure that you're okay. And if you're not okay, to get you out. So those are the two most important things, kind of like blanket statements in terms of caving. For my own personal practice, when I take new people caving, I kind of have a safety talk that I give, and it's kind of just the common sense stuff like, hey, the cave is dark, the cave is cold. In Virginia, our caves are around 54 degrees year round. That just has to do with our latitude and longitude. So hypothermia is certainly a risk. So I talk them through that. If you get wet, if you get cold, if you start shivering, let me know. We'd rather get you out sooner rather than later. And I talk about all the things that, it's dark in here. You've got a light on your head. There's a lot of shadows. You're going to be inclined to jump, and you're probably going to make a bad decision if that happens. So don't do that. And general safety things. And then I always throw out that if you have a medical condition that requires you to carry a medication, hey, just come let me know before we go in if you don't mind. A lot of times people will come up and tell me what medicines they're on if they're kind of worried about them. A lot of people are carrying EpiPens and things like that. Just as a trip leader, those are helpful things to know. Or sometimes people will come up and they'll tell me, oh, hey, I have a bad back or a bad knee or whatever. And I'm like, oh, okay, cool. It's good to know. Try to keep that in mind as we go through the trip. And if it starts to act up, let me know. Beyond that, I don't necessarily have any special questions that I ask people. Bree, do you have anything that you ask people different?
I agree. All those things, kind of talking about getting ready for the cave, changing clothes once you're out, all those good things. And then bring your medicines if you have them, talk about allergies. I say musculoskeletal problems could be kind of the main thing because caving can be very physical, very active. And if you have like a bad knee or back or something that can act up, you just want to be wary of that. Specifically, before descending into a cave, you'd want to have gone horizontal caving first. So caves are either horizontal or vertical. And so most new cavers start in a horizontal cave where it's walking, or basically no proper ropes are needed to get to areas. And then once you've been in the cave environment is typically when you can start doing some vertical caving, where you have rope systems and, caving, we have special harnesses, special descent devices like a gree and an ATC are really not going to work in a cave. So we have our own descent devices, ways to ascend the rope, all sorts of things that you need to know before you go into a vertical cave.
And then Michaela, kind of further the precautions we can give. We've sort of entered this era where people who want to see their family doc or talk to their friend who does cool stuff like everybody in this group likes to or does actually do, they're not really looking for approval to do something. They're looking for ways like how they can do it with their current limitations or their current conditions, and they're still going to do it. So you're going to have things that people have comorbidities with or limitations with that we might not have seen in the past, because people just are like, I'm doing it no matter what. I just want to see if you have tips. So you might see some interesting people in these locations, no matter what, if it's caving, skiing, snowboarding, or whatever. Particularly our large group down in Bonaire, there is absolutely no recertification or like skill checkoffs once you're certified. It's just like, all right, you're probably good for the whole life after you trained at 15 years old. But we're just seeing that more and more of any activity. So just be aware.
Thank you all.
Do you all think it's fair or not fair to tell folks who are immunocompromised that they can't go caving?
I mean, you can warn them.
Yeah, I would agree. Like, I'm not in a mindset to tell anybody what they can and can't do. Rather just inform them of the risks. But if I had an immunocompromised friend that wanted to go caving and they had a full understanding of the risks, I'd go caving with them. That's their choice, as long as they understand it.
Yeah, that makes sense.
That said, if you're immunocompromised, histoplasmosis and blastoplasmosis are real concerns. Like, I would stress that those are diseases they don't really want. So,
our one friend who was immunocompromised for a while that might be listening to this call made the wise decision not to go caving while immunocompromised.
I would agree that was wise.
Can you guys touch just on a little bit about like the certifications specific for cave rescue and cave and spelunking that you have? I don't think we've touched upon that at all.
Yeah, absolutely. So just some terminology. Splunking is kind of like people with a flashlight going in a cave, Billy Bob, walking in this hole. Versus like, we'll say caving is like proper, you have 2 or more sources of lights, batteries, cave suit, etc., a helmet, ideally a map of the cave. So the National Cave Rescue Commission, or the NCRC, is part of the NSS, the National Geological Society, and that's where you can go to get training in cave rescue. There are 3 levels, level 1 being the lowest, 2 and 3. Each of those advance with rope skills, technical skills, more medical skills each time. And then, you can further go to get kind of see if you want to be an instructor, more courses. There are some individual courses. So the NCRC is kind of our standard training. It's held throughout the country a couple times a year. Most of the courses are a week long. Some of them, like Blacksburg, just had a 3-weekend modular course. And then you can also do classes called Small Party Assisted Rescue.
Is she the only one frozen?
I think she might be.
Uh-oh.
I can kind of pick it up where she left off.
Yeah.
So, in terms of training, as Bree was saying, we've got the NCRC, which is like the umbrella organization that provides all the rescue training at multiple levels with, kind of interest in different disciplines. But most people that learn caving, the basics of rope technique, learn that at the like club level, the grotto level. So the little like local cave club is where you kind of learn what we call SRT, or single rope technique. In the world of caving, it's most efficient to throw one rope down the pit and rappel down it, and then climb back up that same rope with as little gear as possible and as effectively as possible. So we spend an awful lot of time like nerding out on building efficient climbing systems for going up one rope. And of course, in a cave, abrasion is a big concern. So we spend a lot of time like figuring out how to deal with abrasion. But most of that training kind of happens locally. And then once you kind of progress through the rescue training, so the NCRC only provides training. It is up to each individual locality to come up with their own rescue teams and then certify people to do different things and send them out and, come up with a dispatch system and kind of push it through at that level. I see another question in the chat about caving precautions and whether they're universal or they depend on the geology. In general, a caver who is proficient at single rope technique and understands, limestone and kind of the risks that you're going to see with it and karst hydrology is ready to go pretty much anywhere in the world that there are caves. A lot of my friends here in Blacksburg, they cave in China, they cave in Mexico, South America, like wherever the karst is good is where they're often caving. The thing that changes with each individual environment is generally the temperature. So, as you get closer to the equator, the temperature inside the cave gets a lot warmer, and that starts to present other different problems. So here in Virginia, actually, I think our cave temperature is close to ideal. It's cool enough that you can wear like a Cordura cave suit that covers pretty much your entire person, and you can put knee pads in it, and you're generally not overheating most of the time. But as you get warmer and warmer, and as you get into central Mexico, some of the cave temperatures down there hang out in the high 70s, and that actually gets pretty warm, like as you're doing a lot of physical activity. And then it's little things like the flora and the fauna that you're going to experience at the surface can cause some concerns and some problems. The sort of the cave insects in Mexico are terrifying just to look at. The cockroaches are as big as your fist. And then they've got these scorpion bugs that run around and eat the giant cockroaches. It really blows your mind. But yeah, no, if you have the basics of safe caving in terms of rope work and understanding geology, you can take it anywhere in the world.
Hey, I'm back. Sorry about the brief interruption. Our Wi-Fi pooped out.
No worries, Bree. I think I picked it up where you kind of left off, and we were just kind of wrapping up on the NCRC and then local training. And then we were kind of talking about how caving is kind of portable. You can take it pretty much wherever you want. And talk about Mexico. I should have also mentioned that some of the most interesting caving in the United States right now is happening up in Montana in extremely cold caves. So like your average ground temperature up there in the summer is still hanging out in the 30s. So it is very cold caving. But some of the deepest caves in the United States are up there. They're not quite approaching like the depth of the system that we're looking at. We don't have a 1,000-meter cave yet, but we're not far off, believe it or not. So some of the caves up there, Tears of the Tortoise, are looking pretty incredible. So, and that's hardcore caving on another level. My friends go up there, and I have no interest in following them. I'm like, you guys have a good time. It sounds cold and miserable.
Yeah, there's some caves near us in Bon Air, and I have to stop myself from going in without a helmet, without a proper light and everything, because they look really fun.
I think to combine those two activities, somebody just set the like underwater cave duration record. It was like they did staged portions where they could like rewarm out of the water, and they were down with staged tanks throughout too. I think they had 2 rebreathers. So people are combining diving with caving, which combines both risks. Anybody done? I've done swim throughs, which is already a little sketchy. But anybody done cave diving? Probably not. Probably
Yeah,
not.
we have.
I'm not a cave diver, but we have several divers in our community here in Blacksburg and around that have cave diving. Statistically, if you are pushing the frontier, like there's 2 kinds of cavers in the world. There are what I call tourist cavers, which is not an insult, like it's a compliment. People that want to go to caves that have already been sort of explored and mapped and look around and enjoy them. And then there's exploration cavers. People that want to go to caves that have never been explored, go in and make the map. So the same is true of cave diving. There are tourist cave divers. And so if the cave is already known, and well understood, then the risks are lower, but they're certainly not zero. Cave diving is among the most dangerous things you can partake in on the planet. And then exploration cave diving is even more insane. So when you are knowingly going into the deep in a world that becomes completely blacked out in an instant. So no matter how powerful your lights are, unfortunately in cave diving, anytime you kick your flippers, you run the risk of silting the passage up completely, losing all visual awareness, and only having the option to get out by the line that you have already laid, that you put your fingers around like this to stay on. So if your fingers become disconnected from the line, that's how they all die. It's very mind-blowing. But yeah, we do have some local divers around here. It is not for me.
All right. Any other questions or comments on caving and cave rescue? It's one of the more, I mean, not niche per se, but I don't think this is often discussed in settings like this. So any questions for people who we actually have on here who do
There's
this?
a documentary called
Dave's
Not Coming Home. If you want to know more about
Cave dive rescue / recovery.
Yeah. Not coming home makes me think recovery.
Correct. I don't know, trying to give away what's going to happen. We didn't show it to our fellows before our dive trips.
Good.
But now that they're certified divers, they can watch it.
Yeah.
But they should never go cave diving.
Yeah.
Yeah.
And then the documentary of the Thailand cave rescue is phenomenal. Discusses caving, incident command system, multinational cave rescue, and then cave diving as well is a huge part of it.
And, giving kids ketamine and then putting a mask on them and taking them underwater. Yeah, I haven't seen the Hollywood version, but the one that you can get on, is it National Geographic or is it?
Mm-hmm.
Yeah, that one's awesome.
Yeah, like just the original basic documentary is fantastic.
Yeah. When you have experts, you listen to them. Basically, that was a giant point of that. All right, well, I think we've pretty much covered at least the beginning stages of getting into cave rescue. So I'm going to end recording at this point. If anybody wants to talk about other stuff, I'll hang out for a little bit after that. But thank you, Eric and Bree, for joining us and lending your expert input, and then Jory for presenting both articles. I'll see you next month. This is the end of the series 6. So anybody who is interested in FOM credits, those will be coming out sometime within the next month, and information on the website on how to submit those for credit. And then January is the start of our next 6-month series. So looking forward to that one. I'll see you soon.
And anyone, if you're ever in the Blacksburg area and you want to go caving, just hit me up. More than happy to take you on a cave trip. My email is real easy. It's my dr period and then my name at Gmail. So